I'm from Italy, and I'm a surgeon and prosthodontics and periodontist. I practice in my office in Manfredonia, in the south of Italy, and I work with the University of Foggia. Today I'm here thanks to Claudio from OsteoTouch that invited me to share with you all my cases and show the application of this magnetic mallet. So let's go on and let's see what is the magnetic mallet. Magnetic mallet is a mallet, but there are several differences with a normal magnet. The first is that there is a magnetic acceleration inside the machine that reach 5,000 G. So it's 5,000 times the gravity acceleration. You have several surgical tips and you can use them for different applications. Today, we will see only a little part of all the several applications of magnetic mallet. So it's like to have two instruments in one. You can imagine to bond a magnet and all the other instruments usually you use with the mallet. Another important characteristic of the magnetic mallet, is the tip has an excursion of only 1 millimeter. So why magnetic mallet? No, it's better to talk why not. Let's see the several advantages that we have with this machine. First, visibility. There is no irrigation. The machine works without water, so you can improve the visibility during your surgery, especially in the lower, in the posterior area of both the jaw. The precision, because all the tips work on the axial direction, in the same direction of the force. So is more predictable the direction of the vector of the force when you use this machine. The control, because you have two hands to control the position of the tips, and is very precise, especially when you have to cut the bone and to control the direction. And it's safe because the force are controlled and the excursion of the tip is only 1 millimeter for every pulse. You have a pedal that give the power to activate the machine. You have a pedal only fast. All these are to produce effect on the compared. Is ergonomic because it's two instruments in one, and is very conservative. Okay, it's very conservative because you can expand and push the bone. If you talk about implant insertion, when we use the burr, we remove bone. We make an hole in the bone, removing the bone. With this machine, we don't remove the bone. We expand, push, press, and move the bone, and is very conservative. Another advantage is that when we use magnetic mallet, we have a low cases of benign paroxysmal positional vertigo. Is a very not comfortable situation that you can avoid using this machine. This problem is caused by the movement of the octonia or otolytis that produce vertigo in the patient after using mallet, not in all the patient, but is reported after surgical procedure like sinus lift, split crest. With this machine, is reported that the cases are there are no cases of this problem. So no benign paroxysmal vertigo. In this moment, in this historical moment, it's also important to underline that is also more safe because we don't have no spray, especially during the extraction. We use the burrs. In this case, we are not using burrs, we don't have spray and aerosol. So comparing during extraction, we can see all the blood and saliva that are pushed all around. With this machine is more clean and more safe. So let's compare also the effect of the magnetic mallet compared with a traditional mallet, which is the most important difference. This is a graphic of the forces, because this machine has 4 forces from level 1 to level 4. All the forces are expressed in 120 microseconds. And as you can see from the graphic, the pink line is the time of application of the traditional mallet. So it's a long time. It's a long time that produce the same effect. In the other lines, the red, the green, the blue are the graphic of the forces from the 1 to the 4 when you use magnetic mallet. The force is higher, is bigger, so you can use more power, but the time of application is dramatically shorter. So the effects are produced in a very little time. And this is the reason of the safety of this machine comparing with a traditional mallet. This is the reason of the no presence of the vertigo, and this is the good effect on the bone, because if you use the cut tips, the effect of cut is very fast and don't produce heat, don't heat. Okay. So what is magnetic mallet for me is an Italian masterpiece. I'm sure about that. Let's see clinical application. The first application, the most common application that you can try is the site preparation for implant insertion. Let's see, this case is a courtesy of Dr. Luigi Cannullo. Dr. Luigi Cannullo, if you want to ask something, I have to open the chat. Okay. Sorry. Text later the question, because during the presentation I can't read. So this case is a courtesy of Dr. Luigi Cannullo. He's an aesthetic area in this patient. As you can see from the provisional restoration, we have a volume defect, an horizontal volume defect. And to have a good aesthetic result, we need to increase the volume. How we can increase the volume? We can increase with a split crest or a bone graft or a soft tissue graft, a connective tissue graft. But in this case, the doctor used only the magnetic mallet to produce a bone expansion, increasing the volume without using the burrs and without graft. This is the result with the provisional restoration and the X-ray of the try of the definitive abutment. We can see we can see the volume that he reached only using the mallet, and this picture shows a 4-year recall. Let's see a video. This is a video showing how to prepare the site. So we start elevating a flap. We start like in a normal implant procedure. After the gum incision, we can elevate the flap to expose the bone. We start with the first tip. This tip allows us to choose the place of insertion, so the emergency, the prosthetical emergency, the position, the right position of the implant, and the direction of the implant. For every push, the instrument goes inside the bone for 1 millimeter. On the instrument, we have laser marks that show the depth, so you have to know the length for every mark. Pushing and pushing, you can start producing an hole in the bone, and you produce an expansion of the bone. If the bone is a soft bone, you have osteodensification. You increase the density of the bone. So starting from the first tip, we go with the osteotomes of a wider size to reach the size of the final burr that we usually use for an implant, for the implant insertion. Moving the insert, we can remove the insert from the bone. At the end, we insert the implant, and you can see how the bone is shaped. There is an expansion that produces an increase of the volume of the bone. So we can finish, and during the insertion of the implant, we can check the torque. In every case, we have a great torque because the bone is condensed, is pressed by the osteotome, and we often, if not every time, but very, very often, we can reach a high stability of the implant. In fact, in this case, we can insert an healing screw at the surgery time. We can end the procedure with a suture. This is a normal, simple case of implant insertion. As you can see in this case, this was a lateral incisor. In this case, using only the mallet, starting from a very narrow crest, we can increase the volume using the wider insert, the wider tips, to reach this kind of preparation. So we changed a narrow crest in a wide crest to receive an implant, a narrow implant, but without any kind of bone regeneration or grafts. I like to call all these kind of procedures like bone shaping. We can shape the bone in in every kind of situation. We can push the bone, we can enlarge the bone, we can change the bone in a higher bone, like in the following cases. Let's see this case. This is a very challenging case because this patient arrived at my office with this bridge. This bridge was lost because of the fracture of both the abutment. This bridge is 5-crown bridge on 2 abutments. The abutment were the canine, so the 1.3 and the 1.7. Let's see the X-ray, but we have to check the 3D exam. The important thing is this patient called Anna. She is 65 years old. very emotive and scared. This patient was very scared about the surgery, but she asked for no removable solution, no removable prosthodontics, only a new bridge, and of course we needed to insert implant. And because she was very emotive and scared, she asked as few surgery as possible. So these are the endo X-rays, the 2D exam that shows the fracture of the 1.3 and the 1.7 teeth. Sorry. This is the 3D scan exam. As we can see, on the molar side, we have enough bone, and the same is on the root of the canine of the 1.3. But in the middle we have no bone. There is a narrow crest. So if you want to insert an implant in the middle area, we need to expand the bone. We need to perform a split crest. So let's see the several images. You can see the first image and the second image are the area of the molar. The molar, we have only 6 millimeters of bone in the 8th, but it's very wide. It's 10 millimeters wide. In the middle area, there is a narrow crest. Is less than 4 millimeters, but we have it seems that is high, 14 millimeters. The point is that moving distally, we have a dramatically decrease of the 8 because there is the sinus. The sinus is waiting for us. So it's very dangerous to go straight with burrs because it's possible to finish into the sinus. And in the last image, we see the situation on the root of the 1.3 tooth. There is enough bone, but there is a very thin buccal bone, and we have to try to leave that bone, starting from the extraction and finishing with the implant position. This is the clinical view after removing the bridge. The bridge was floating on the gum, so we had to remove the root and proceed with the implant insertion, and if it was possible, also an immediate loading. These are the extraction made with the insert for extraction and using the magnetic mallet. Magnetic mallet allows to remove the root, saving the bone without break the bone and saving all the very thin buccal bone. This is the view, the intraoral view after the extraction. And let's see what we have to do to insert the implant here. This is the first implant, the 1.3. In the 1.3, we don't have to follow the direction of the root. We have to change the direction of the root. And to choose and guide the first drill, usually we use a lancet burr. In this case, we use the first tip. The first tips allow us to choose the best direction for the implant. So we start with the first tip. After engaged the bone, we can change the direction gently using the second insert in this way. And after that, we can change more, and using a wider tip, we can finish the preparation and guiding the implant insertion in a perfect prosthetically position, because I wanted to finish the case with a screwed bridge, and I wanted the hole of the screw in the palatal zone. So in this case, we can check the direction with the axe of the tip. And this is the 3D after the implant insertion. You can see how that little piece of bone is saved from the insertion. On the last tooth, on the molar area, the 1.7, this was the situation. We had enough width, but we needed to perform a mini sinus lift, a crestal sinus lift, to insert a longer implant. So we start with the first insert, the first tip, to produce the first hole. After that, we can use the second, and we can go deeper, because with the first insert, we have to stop under the sinus. With the second insert, we can push the bone up. After this, we can change the tip and use a wider one to push the bone higher. And going with the wider, we can move the bone, the floor of the sinus higher, to reach with the last insert the final length that we want to place the implant. So after that, we can insert the implant in the best position and with a sinus lift in a very gentle and safe procedures. This is the X-ray after the implant insertion. You can see I only broke the sinus floor because I didn't need to lift more than 1 millimeter the sinus to insert. This is a wide implant, 8 millimeters and a half length. But this was the most challenging site, the intermediate implant. The implant was in the position 1.5. In this case, we have a narrow bone, and we have to enlarge it, but we also have the sinus. So we have to perform a mix of procedures. This is a cocktail. Starting with these different insert. This is from the kit for split crest. This is the cut, and we can cut the bone. So we start cutting the bone exactly in the middle. After that, we can use the expander. Using the first expander that is wider, we start to enlarge the width of the bone. After that, we can use the second expander to move the bone to realize the fracture of the vestibular bone. After this, we need to lift the sinus. So we change the kit and we start with the osteotome. We start not with the first osteotome, but we can start with the second, and then with the third, and then with the second, the first, and the fourth, and at the end we can insert the implant. I can show you the final image where with the dramatic change of the bone. I reshaped it, I enlarged it, and I pushed up the sinus floor before insert the implant, only using the magnetic mallet. These are some images, few images during the surgery, the insertion on the implant 1.3, the insertion of the implant 1.7. During the surgery, I try to perform more procedures in the same time. In this moment, I'm grafting some connective tissue because I wanted to protect on the first implant, 1.3, to protect the implant and to increase the volume. So I performed in the same surgery also a connective tissue graft to increase the thickness of the soft tissue on the implant 1.3. This is the bridge. The intermediate implant, the 1.5, doesn't reach enough stability for the immediate loading, and this is the provisional bridge that I loaded at the same time. And this is other images. You can see in the intermediate implant how big is the piece of the implant floor that I broken and I pushed it up. Other images, the 1.3, and this is the 1.5. Okay. I want to show you another case. This case is the osteodistraction to avoid the sinus lift. This is the start of the procedures. The patient arrived with this bridge, and she asked me to insert some implant to produce a new bridge, to realize a new bridge on the implant. On implants. This is the situation. The first route was enough long for me to be finalized with a traditional crown. So I wanted to insert an implant on the next site, so the 1.5, the premolar area, and I decided to remove the root of the 1.7. In this situation, which kind of option we have? Of course, if we want to insert some implant here, 2 implant, everyone usually think about a sinus lift. We have different options to avoid the sinus lift, but till yesterday, I always performed a sinus lift before insert 2 implant. Today, we often listen about tilted implant. So we have also this option to insert the implant in this way. We have different problems. The first problem is on the implant 1.5, that is possible to touch with the implant the root of the 1.4, and it's also possible to enter inside the sinus with the burrs. Other problems are on the posterior implant, the 1.7. The posterior implant is very difficult to perform this angulation, but the very big option, the very big problem that you can find is when you have to finalize with a bridge. If you want to screw the bridge, I prefer every time when it's possible to finalize the case with a screwed bridge. So you need some multi-unit abutment. As you know, multi-unit abutment have a very small screw, and it's common to have broken screw inside our bridge. So if it's possible to change this option, for me is better. But another problem is that when you finalize with a bridge, we have some problem with the cleaning, because you have big spaces, interproximal spaces are very large, and you have food impact. So let's find a different way to avoid the sinus lift, but also tilted the implant. And this is using magnetic mallet. I'll show you a video that of this surgery to perform the osteodistraction. You enter with the first and the second insert in this direction. You have to enter from distal to mesial to engage the most bone as you can with the first insert, like if you want to touch the root. After this, you have to turning the insert. We have the fracture of the sinus floor that is moved distally. We go on changing the insert and going with a wider insert and doing the same things, but in this situation we start with a more mesial direction, and after during the insertion we can turn and move the bone distally. In this case we had also another problem. The problem was the length of the abutment of the root. For the ferrula effect, we needed to perform also a crown lengthening, and when it's possible, I like to perform all the surgery in the same time. So in this case, I performed the extraction on the 1.7. The sinus lift, the crestal sinus lift of the 1.7, then the insertion of the implant 1.5 with the osteodistraction to reshape the sinus floor and avoid the sinus lift with the lateral approach. And in the same surgery, I also performed the crown lengthening to enlarge, make longer the abutment, and to finalize with a crown with a good ferrula effect. I want to show you the surgery. This video is we are more on the half of our presentation. This video show in detail the procedures and the use of the magnetic mallet for the bone destruction. So this is the beginning. We start with a kit for the extraction. The extraction is possible because there is the cone effect. When the insert comes inside the ligament space, this tip is to cut the ligament and to create the space for the following tips. So when the tips enter, the bone is compressed and detached from the root. And as you can see, at the end, the root will jump out in an easy way, saving all the bone. The inserts are very strong, so you can use them like traditional elevator, but often you don't need to apply the force. So after the extraction, we start with a flap design, and in this case, we had to perform also a periodontal surgery. So the flap is designed for a crown lengthening. We have the different incision from vestibular to palatal, because vestibulary we have to save the keratinized tissue. In the palatal area, we can remove some soft tissue, and it's very important to choose the good direction of the incision, because we want to reduce the thickness of the palatal flap. So we have the first flap and the second flap. After the elevation, we remove this piece of gum, but in this case, we have to save this piece of gum, okay? Because at the end, I will use it. So we go again in the vestibular area. We clean everything. We remove the interdental papilla. And we start with the first tip. The first tip, as you can see, is from distal to medial, because we want to be sure to stay in the native bone. So the direction is bending, is not orthogonal. The direction is like if I want to go to touch the root of the 1.4. In this way, I'm only sure that I'm inside the bone. I don't want to stay near or close to the sinus. It's around 45 degrees. I check the length because I want to insert a 10 millimeters implant. As I'm showing that I start from distally, but during the insertion, I'm moving more mesially. I'm moving more mesially. I want to push the bone with the top of the tip. I want to push the bone distally. I want to move the sinus floor. I'm entering. I want to reach the laser mark at 11 millimeters, because my implant have to be in place at 1 or 1.5 millimeters under the bone level, subcrestally. So I'm going deeper and deeper, and in the same time I'm going deeper, I move the insert mesially to make it more straight. I'm changing the tip, and again I start from distally and gently I push, gently. We don't have to run, we have to leave the bone to expand and move, and we have to produce the fracture of the sinus floor. I change the insert, I go with a wider, and I want to go straight now, because I start from distally, but the implant that I want to insert have to be straight to allow me to finalize with a screwed bridge without using the multi-unit abutment. So I'm pushing, and as you can see, for each activation of the magnetic mallet, there is an excursion of 1 millimeter. The patient can't feel any pressure. The patient only hear the rumor of the machine, the noise of the machine, sorry, but she doesn't feel the hip, the pressure. So I reached the length, I checked the length, this is 11, the 11th burr, and I want to go deeper because I want to insert the implant subcrestally. I'm sure that the direction is good, and at the end I can go with the implant. I insert some collagen because I don't want, after the fracture of the sinus, that the implant threads can produce a laceration on the membrana of the sinus membrane. I'm inserting the implant, and I put it very deep because I have to finalize with the crown lengthening. On the back, on the 1.7, I need only to crush the floor. I have other 10 minutes to finish my presentation. If you have some question, you can text on the chat and I'll answer to everyone. After the break of the floor, I use a novel approach, is called creek technique, that allows us to elevate the floor only skewing the implant. So I use the mallet to have a fracture of the sinus floor, and then with the implant I elevate the sinus. The stability was good. I put the healing abutment, and then I moved to the root for the crown lengthening. This is nothing special. It's a traditional crown lengthening to have at least 3 millimeters, but 4 is better, of root to have a better stability. So we start removing the bone. You have to reshape the vestibular and interdental area, and then we can prepare the root. In this way, you remove the periodontal attachment from the root, and you have the final preparation of this area, and in this way you don't have to touch the tooth again. It's only one step surgery. In this moment, do you remember the flap when I removed the gum? Now I'm using that piece of gum for a connective tissue graft. I'm grafting this tissue on the first implant because in this area the ridge was narrow, and in this case I always use to graft some connective tissue, and it's always better to do it in the same time. This is to prevent further problem about aesthetic, and also to prevent periimplantitis is showed. So we finalized the surgery with periodontal suture. These are external suture to stabilize the tissue and to compress the tissue against the bone. Okay, I don't use any graft in these cases. I only reshape the bone, I press and push the bone, and I leave the space to be filled from the blood. So in these procedures is also more cheap for the patient because we don't have to use any kind of graft. We use the patient's bone and the patient's soft tissue to increase the pink aesthetic. Okay. I put only some collagen to stabilize the clot, because more stable is the clot and better is for the healing. But what I want to show you is the final result using the magnetic mallet to reshape, recontouring the sinus floor. Okay, this is collagen that I put around the healing screw because I want the healing on the collagen. So let's see, this is a 1 month recall, and you can see how changed the sinus from this situation at the beginning, the red line, to the green line. I changed completely the contour of the sinus only using the bone distraction. I have a good implant position for a screwed bridge, and performed also the crown lengthening on the root 1.4. These are some pics at the time of the surgery, and this is the healing only at 7 days. You can compare with the procedure of the sinus lift. Is dramatically less invasive. Talking again about site preparation, I want to show you, sorry for these pics, but this case was dramatic. This patient was a 3rd class, skeletrical 3rd class, and he asked for a fixed prosthodontic bridge with immediate loading on implant. In these cases, we have no bone. The only area of the bone were the frontal incisor area and the premolar area near to the sinus. And in these cases, I planned to perform an all-on-4 technique. You can see the bone was only in the position of the incisal bone, and immediately on the back, we have the sinus. So in which way we can insert the implant, saving the sinus and without using the bone? Of course, with magnetic mallet. This was the 3rd class, so we have a very bend force on this area, and to protect the immediate loading, I decided to insert 2 more implants on the tuberic area. On the tuber, you know, on the tuber there is a very, very low quality bone. the tuberic bone is not good for immediate loading, and often when we insert the implant, we can't load because the torque is very low. So I decided to insert the implant using magnetic mallet also in the tuberic bone. This is the last case. I want to show you the clinical images. This is the situation. It seems good, but after the flap elevation, you can see the situation was dramatic. We have bone only in the frontal area and on the back, but on the back there was the sinus. So I used the burr only in the position 1.1 and 2.1, but on the back I started with magnetic mallet and I finished with the magnetic mallet. These are the implant at the time of the insertion, and you can see on the distal bone I insert 2 more implants on the tuberic bone. These implants are insert after the preparation with magnetic mallet, and the bone moved from a D4 to a D2 because I reached 50 Newton centimeters of torque. So I was allowed to charge, to load also these 2 implants. I placed the multi-unit abutment. This is the moment of the impression with a particular technique, and this is the delivery of the provisional restoration. But the most important things is the final X-ray after the provisional loading. You can see the implant 1.4 that is very close to the sinus, and this was possible because I didn't use the burr. I used only the mallet. The mallet don't open the sinus, but the mallet pushed the sinus, and you feel more safe to insert the implant very close to the sinus. And the other effect is to increase the bone density. Increasing the bone density, you often, if not often, very often, you can load immediately the implant. I want to say thank you for your kind attention, and now I can close the presentation and read your questions. Okay. Okay, if you have some question, I can. Contraindication. Thank you, Brahman. Thanks, Dr. Mel. Can you do this kind of sinus lift if there is a sinusitis? Yes, because sinusitis don't allow you to perform the traditional sinus lift if you have to elevate the membrane. But with magnetic mallet, we work on the membrane. We work on the bone, and the bone, after the using of the osteotomes, is pushed in the same times with the membrane. So I never think is a problem to use in sinusitis. Of course, we have to divide into chronic sinusitis or acute sinusitis, because if it's acute sinusitis, you have first of all to treat the sinusitis, and after that you can perform your surgery. Contraindication. The only contraindication of the use of magnetic mallet is the density of the bone. You can't use it on bone D1, D2. In D1 is not possible. You have to use the burr. But this is why. This is because I use often, if ever, every time I use the magnetic mallet on the upper jaw, but I use it less often in the lower jaw. Because if the bone is too hard, you can't shape it. You have to use the burr, And after that, after the first of the second burr, you can start using the magnetic mallet. Do you have more questions? Do you use any bone graft in crestal scenario? Okay, there are two kinds of approach. There are two kinds of approach, Peter. Some clinicians use the graft. I don't like. I prefer to use the bone, reshaping the bone, because the biomaterials are good to increase the volume, but every time you can avoid the use of biomaterial, for me it's better. You have the healing with native bone, not this hybrid bone that you used to see after the healing when you use bone graft. So I never use bone graft with magnetic mallet in crystal sinus lift. I use the graft only in the GBR and in lateral approach of sinus lift. Is the same as the piezo drill? No, it's dramatically different. The piezo is completely different because the magnetic mallet is like a mallet. So you push the bone. The piezo cut and remove the bone. So at the end, with magnetic mallet, you have 100% of the original bone. With the piezo, you lose something. And with the piezo, you can only cut the bone. You can't push and split. You have to cut the bone, and then you have to use the osteotomes. It's better to use one machine to cut and enlarge the bone at the same time. Resorption after extraction. Resorption is the same of every kind of destruction. I performed destruction for many years, and I saw a few resorption is around 5% in volume. With the magnetic mallet, for me, is you have less stress on the bone. There is no heating, no warm. You don't increase the temperature, so you are more gentle. And for me, the resorption is less comparing the other instrument. For the more complicated case, you use the guide. Yes, I use the guide, but is more for the position, for the prosthodontical position. When I have complicated case, I prefer to open everything and guide with my brain and my hand. Versadrill and mallet. Versadrill are good. I have also Versadrill, but the mallet is Versadrill are with the motor, so you have an increased temperature. There is a more thermal effect on the bone than the mallet. The mallet doesn't produce thermal effect. Peter, what is the minimal height of bone in crestal sinus elevation? This depends on the personal experience. Usually 5 millimeters is a good beginning because you can insert an 8 millimeter implant. Today, the evidence-based medicine show that 8 millimeters is enough for an implant. And the most common size of the bone is 5, 6, 8 millimeters. So we very often can insert an implant of 8 millimeters or 10 with a crestal approach. Only in the moment that in that cases that you are not so often in our office with 1 or 2 millimeters. So in that cases, you have to perform a lateral approach. More question? Okay. So if it's okay, I hope I showed you something interesting about a different kind of vision of the bone surgery, like to perform the same procedures but in a different and more safe way with this machine. For every kind of question, I left my contact email and you can text me. Do you use magnetic mallet, Peter? Yes. Often you have in the posterior mandibola, in the old women, a cortical bone, and inside you have a D4. When you read the cross section of a CBCT, you see the black bone. The black bone is a disaster for implant insertion in mandibular bone. So it's good to perform the first hole with burrs only to open the very hard cortical bone. After that, using magnetic mallet, you have the osteodensification, and with this osteodensification, you can insert implant with high torque, 40, 50 Newton per centimeter. And this is very important when you need to load immediately the implant. But these cases are very not common because in the mandibular bone we often have D1, D2. So I prefer to use in the maxilla. Okay. Okay. So thank you for your kind attention, and I hope I will meet you all in the future when this epidemic moment will finish. I hope you will be safe at your house and enjoy your life. Bye to everyone.
The magnetic mallet uses advanced technology for minimally invasive surgeries. Try it yourself.